today we're going to go into Dysphagia, which is chapter 11 in the 5th edition, page 381 to 390, so not the whole chapter. We're going to go over feeding versus swallowing. We'll introduce anatomy related to the swallowing and the 4 phases of the swallow. We'll also talk about what dysphagia or trouble swallowing is, the symptoms of dysphagia divided by the 4 phases of the swallow, and the assessment and treatment related to the speech therapist. So this should look familiar to you. We're talking about feeding and swallowing and how they're related but not quite the same. So last class we talked about feeding as the transportation from food from the plate to the mouth. And that can be exhibited as a disorder if the child refuses that food, either because of a medical, psychological, neurological, or behavioral problem. So usually when we talk about feeding, we talk about it with infants and children. If something along their development caused an issue with them being able to accept a variety of foods that are age appropriate. When we talk about swallowing, on the other hand, we're talking about the transportation of food from the mouth to the stomach. So it begins with the food in the mouth, and then it's described in stages as the food continues through the throat, into the esophagus, and into the stomach. And it's described across all ages. So when we talk about swallowing, it's really you sitting down and having a bite of steak, chewing it up, and getting that steak down into your stomach. It can also be you taking a sip of cold water and taking a big sip versus a large sip, or taking sips back to back, or from a cup or from a straw. And that's really talking about the safety and efficiency of the swallow. So can we keep the airway protected while we're swallowing so nothing makes us cough or choke? Or can we keep things from sticking in the throat? So think about the last time you had a bite of peanut butter or something really sticky and how it stuck in your mouth. Or you had a bite of cracker or a piece of bread, and when you swallowed it got stuck in your throat. That's the efficiency of the swallow. Does anything get stuck that can cause a problem? So the first thing we want to go over is anatomy. So anatomy really starts for swallowing in the brain. We have 2 different types of neuroanatomy. We have the neuroanatomy that's responsible for the voluntary stages of swallowing, which means that we have control with how long and what happens during this stage. And then we have the neuroanatomy for the involuntary stages of swallowing. So we have no control over how long or what happens during these stages. So the primary motor cortex, the premotor cortex, and the primary sensory cortex initiate and modulate the movements for the voluntary stages of swallowing. So this is the oral preparatory and the oral phase. And we'll talk about these phases in just a little bit, and it might make sense to you why they're the voluntary stages. Then we have the medulla that controls the involuntary stages. So these are the pharyngeal and esophageal phases. And these areas communicate and give us signals to the swallowing muscles and the structures for swallowing through the cranial nerves. So there are 5 cranial nerves important for swallowing, and they give us our sensory and our motor functions. We have cranial nerve 5, 7, 9, 10, and 12. So the trigeminal nerve gives us the motor function for biting and chewing. It also gives us the sensation for the temperature when we're eating, and for the oral mucosa, or that coating of mucosa in the mouth, as well as the front portion of the tongue. And that's important for the oral preparatory phase. And we have the facial nerve that gives us the taste in the front 2/3 of the tongue, and it helps us keep the food in the mouth by helping us close the lips. And this is also important for the oral preparatory phase. And we have the glossopharyngeal nerve that is the provider for sensation to the tongue, the pharynx, and the velum, and also helps work with the facial nerve to give us taste to the back 1/3 of the tongue. So this is helpful for the oral preparatory, the oral, and the pharyngeal phase. Then we have the vagus nerve, and we've talked about this nerve. It has a lot of responsibilities. It helps give us motor function to the upper area of the esophagus. It helps with the larynx and closing during the swallow. It helps close the velum during the swallow, and helps squeeze the muscles of the pharynx closed to help push food down into the food pipe. It also gives us sensation to the larynx, so this tells us if anything is going into the airway and gives us a cue to cough to get it out of the airway. So it's important for the pharyngeal and esophageal phase of the swallow. And then we have the hypoglossal nerve. This is a motor nerve that gives us the function for the tongue muscles to help position food on the chewing surface of the teeth, as well as during the oral phase, moving that food from the front of the mouth towards the back of the mouth and into the pharynx. So when we talk about our anatomical structures, most of them should be pretty familiar to you. We have the lips, the jaw, the mandible, and the maxilla. We have the tongue and the teeth, the hard palate, the velum, as well as the true vocal folds and the pharynx. So what we'll introduce today is the epiglottis, or also the vallecula, the false vocal folds, the esophagus, and the stomach. So you should see here we have structures important for the oral and oral preparatory phase, and those are all housed in the oral cavity. And then the structures important for the pharynx are located in the pharynx, and they help push that food down into the esophagus and close the airway. And then finally we have the esophageal phase, and the esophagus is of course important for the esophageal phase. So looking at our picture here, this picture should be familiar. We have the hard palate here at the top of the mouth, and that includes the alveolar ridge with the teeth. And we have the soft palate in the back of the mouth that will move up and back to close off the nasal cavity and keep food from going into the nasal cavity. We have the lower teeth in the mandible here, and the tongue. So the tongue is going to move around from side to side to push the food onto the chewing surface of the teeth. And then it also moves from the front to the back to move the food into the pharynx. In the pharynx we have the epiglottis, which is part of the larynx. So the larynx is here in the front. Again, the larynx is the tube in the front. And we have the esophagus, which is the tube in the back. So the esophagus is in the back and it goes to the stomach. The larynx is the airway, it's in the front, it goes to the lungs. When we're thinking about swallowing, we want everything to go into the esophagus. We want nothing to go into the lungs. So over here on your right, we have a picture of the modified barium swallow study. This is a video x-ray that we do to assess the swallow. So this is just a x-ray of somebody who's about to go through one of these studies. So we'll highlight the different areas so you can see what it looks like when we're assessing them. So right here we have the tongue. This entire space here is the oral cavity. Up here is the nasal cavity. Then we have the pharyngeal cavity here, the larynx over here in the front, and the esophagus is closed when we're not swallowing, so you can't really see his esophagus very well, but the esophagus is right here in the back. So we'll highlight the different areas. This area in yellow is the hard palate. Then we have the tongue, and the tongue goes back to the epiglottis. The epiglottis I'm going to highlight in green. So the epiglottis is the structure itself. The vallecula is the cup that the epiglottis forms. So it's not an actual structure, it's just kind of a shape that the epiglottis forms. Then we have the pharynx that starts at the top where the velum and the pharynx meet in the back, just below the nasal cavity, and it goes to the top of the esophagus. Then we have the larynx. Again, this is the front where the airway is, and the esophagus is here in the back. What I've also highlighted on this picture is the hyoid bone. The hyoid bone is this little shadow here in the front, just in front and on top of the larynx. And it's important because the larynx attaches to the hyoid, so when someone swallows, the hyoid lifts and helps close. Alright, so now that we have the anatomy, we're going to go through the normal stages of swallowing. Alright, so for the stages of the swallow, we're talking about that transition of the food from the mouth through the pharynx, through the esophagus, and into the stomach. So think about when you're eating a piece of steak, chewing up that food. Chewing up that steak is known as the oral preparatory phase. So you're breaking down that piece of steak and getting it ready to swallow so that the muscles don't have to work so hard to push it down into the stomach. So once we get that food broken down and ready to swallow, we're going to move the food to the back of the mouth. This is the oral phase. So the tongue is going to push up against the roof of the mouth and push that food to the back, Once it gets to the back and contacts the fascial pillars, that begins the pharyngeal phase. So during the pharyngeal phase, your pharynx is contracting and pushing that piece of steak that's been chewed up down towards the esophagus. At the same time, the larynx is lifting and closing. Once that piece of steak passes into the esophagus, that starts the esophageal phase. The esophageal phase continues as that food passes through the esophagus, and once it enters the stomach, it ends the esophageal phase, and that ends the stages of swallowing. So looking at this picture here, we'll again go through our piece of steak. So in the oral preparatory phase, we're chewing up that piece of steak from passing the tongue, using the tongue to pass the food to the chewing surface. And then for the oral phase, we're pressing the tongue to the roof of the mouth and sending that chewed up piece of steak into the pharynx. Once it's in the pharynx, we start the pharyngeal phase. The back of the tongue is then going to push against the back of the pharynx. The pharyngeal constrictors will squeeze together and open up the esophagus, and it starts the esophageal phase, and then that food passes down into the stomach. Okay, so we've talked about normal swallowing. Let's talk about difficulty swallowing. Our name for difficulty swallowing is dysphagia. That just means that something happens during the swallow that makes it hard to swallow either food, liquid, or saliva. There are different causes for swallowing disorders. It can be related to a stroke that causes injury to the areas of the brain responsible for swallowing. It can also be related to a neurodegenerative disease that causes a breakdown in those areas of swallowing. It can also be related to head or neck cancer, either the tumor being in the oral cavity, the pharyngeal cavity, the larynx, or the top portion of the esophagus. Or it can be related to cancer treatment. Radiation or chemotherapy can cause difficulty swallowing afterwards because of stiffening of the muscles, not being able to be flexible to push the different sizes of food into the esophagus. It can also be related to surgery to the brain, head, neck, chest, skull base, or spine. And that's because those surgeries can injure the nerves responsible for swallowing, or they can damage structures. So the pharyngeal structures, the oral structures, anything like that that changes those structures can change the function of the swallow. It can also be related to brain injury, which goes back to if there is injury to an area of the brain responsible for swallowing, or it can be related to HIV or AIDS. When we talk about disorders of swallowing, we can break it down into different phases. So that's why the stages of swallowing are so important. We have to know what happens during a swallow normally so that we can figure out what happens when a swallow is dysfunctional or the patient is having dysphagia. So during the oral preparatory phase, a person can have difficulty chewing, or they can hold food in their mouth too long. This is typical in our patients with Alzheimer's. The more progressive the disease, they'll start holding the food in their mouth and forget that they have something in their mouth, and that puts them at risk of that food going into their airway or spilling into their throat, and they're not ready to swallow. It's also a nutritional problem that they're not eating their food, and so they might have weight loss. We have during the oral phase, they have tongue weakness, so they might not be able to move that food from the front to the back towards the pharynx, and that would leave food residue in parts of the mouth, either in the space between the gums and the cheek, or underneath the tongue, or coating the top of the tongue. During the pharyngeal phase, a person can have a delay swallowing reflex. This means that instead of the swallow initiating at the fascial pillars, it initiates at the top of the esophagus, and it puts them at risk of that food or liquid spilling into the airway because the airway hasn't been closed to protect. They could also have food sticking in the pharynx, so the muscles can't squeeze enough to get all of the food down into the esophagus, so food is left over. And you'll see in this picture down here at the bottom, we have 3 different types of residue or food sticking in the throat. So this dark area right here is food sticking in the vallecula. This person has the food sticking in the top of the esophagus or the bottom of the pharynx. And this person here has residue or food stuck kind of all over. So they have food in the vallecula, food in the top of the esophagus, as well as food in the esophagus. Someone can also have a disorder in the pharyngeal phase where food or liquid goes into the airway. and we'll talk about that in just a minute. The esophageal phase can have inefficient movement of food from the esophagus to the stomach, so that food can really get stuck here in the esophagus or even further down on top of the stomach. Or they can have food backflow from the esophagus into the pharynx, which is known as reflux. So this is really where our neuroanatomy comes back for the volitional and non-volitional movements. So think about when you're chewing up food, you can make that phase last as long as you want it to. Maybe you want to, this is a really tough piece of steak and you want to break it down into really small pieces. And so you're going to chew for a little bit longer. And then when you move that food to the back of your throat to start the pharyngeal phase, maybe you realize that it didn't get chewed up all the way, so you bring it back up a little bit to chew a little bit more, and then you push it back down again. Once we start the pharyngeal phase, we can't really stop the pharyngeal phase. Those muscles contract, and they contract just long enough to keep that food from staying in the pharynx. So it really contracts long enough to push everything down into the esophagus, and if it's not working efficiently, then it's kind of out of our control, except that we want to strengthen up those muscles to get them strong enough to push that food down into the esophagus. And again, once the esophageal phase starts, we can't tell our esophagus to stop. Those contractions are going to continue until the body has been told that the food is passed all the way. So for disorders of airway protection, this is during the pharyngeal phase. We have to talk about what's normal first. So normal airway closure involves 3 layers of airway protection. We have the epiglottis, the false vocal folds, and the true vocal folds. So the epiglottis is responsible for catching the food or liquid before it falls into the airway. And you'll see in this picture here, maybe a little bit better in this picture, this is the epiglottis. And if any food were to spill while the person is chewing, it can be caught by the epiglottis so that it doesn't fall straight into the airway. During the swallow, the epiglottis flips over the airway and closes off the airway. If anything slips past this first layer of protection, we have the second layer of protection where the false vocal folds squeeze together into a sphincter. That way, if anything has fallen in, if they're strong enough, they can push that food or liquid back out and into the pharynx. And then our final layer of protection is the true vocal folds, and those are the vocal folds closed together or adduct to keep anything from spilling into the airway. So if any of those 3 layers fail, we have something called penetration or aspiration. So penetration is when the bolus or that chewed up food or the liquid enters level 1 or level 2 or touches level 3 of our airway protection. So this picture here on the left is penetration, meaning that we've bypassed the epiglottis and the false vocal folds, and the bolus is sitting right here on top of the true vocal fold. So this is penetration, and I'll highlight that for you. That area right there, that dark shadow, is penetrated barium. Over here on the right, we have aspiration, which means that the bolus falls below level 3 and into the trachea. So this person actually has a lot of residue, and so this dark substance you see that's highlighted is barium. So this barium is just coating the back of the tongue, the epiglottis, and it's at the bottom of the pharynx. But what we're really looking at in this picture is here in the front. So this is again the airway. So this is our first layer of protection with the epiglottis. This is our second layer of protection with the false vocal folds. And then right here where you see everything is highlighted is aspirated barium in the trachea. So this is aspiration. And I'll highlight that there for you. Okay, so when we do our assessment, we have different types of assessment, and we do them depending on the tools available to us and what's appropriate for the patient. So the first one is a bedside exam, and that's just where we have the person eat and drink in front of us, and we listen and watch for signs or symptoms of difficulty swallowing, either with coughing because of aspiration, or them telling us that they feel like food is stuck in the throat, or we can listen for a wet voice quality, which tells us that liquid is sitting on top of the vocal folds. Our second type of assessment is a flexible endoscopic evaluation of swallowing, or a FEES. So we've looked at endoscopy before. It's this picture up here on the top, and it's just a camera that looks down into the pharynx while the person is swallowing. So this picture here, we have the arytenoids right here on the top. Over here on the sides is the pharynx. This structure right here is the back of the pharynx. And then right here, this little cup that you see is the epiglottis, and what's sitting in the epiglottis or in the vallecula is macaroni and cheese. In this picture down here at the bottom, we have a modified barium swallow study, which is video fluoroscopy. It's just a video x-ray. So while someone is eating and drinking, we give them a substance called barium that shows up on the x-ray so we can see whether it's going into the esophagus or into the airway or staying in the mouth or the pharynx. So this person is the same person up here at the top during video fluoroscopy. They have a graham cracker in their mouth, and this is what you see here just highlighted. And then they have a little bit of barium here in the vallecula. And then this is their pharynx without any barium at all. And you'll see this little dark area right here in the front is aspirated barium from a previous swallow. So it gives us different pictures and a different idea of what's happening during the swallow. Essentially, we can see the pharyngeal phase of the swallow before and after the swallow happens, but not during the swallow. The video fluoroscopy lets us see what's actually happening during all phases of the swallow. So we can see the person swallowing and how the muscles are closing before, during, and after. And we'll watch a few of these in class. For the management of the swallow, we have 3 different approaches. We have the indirect treatment, which will give the person exercises to strengthen the oral, pharyngeal, laryngeal structures. We have direct treatment, which can be modification of the food consistencies to make them more safe for swallowing. Or if we can't determine a safe diet, then we'll give them a tube or recommend a tube, and the gastroenterologist will place the tube depending on where it needs to be placed. So in this case, this is an NG tube or nasogastric tube. So the tube passes through the nose into the stomach, and the food is given through a syringe and passes through that tube into the stomach. We can also do compensatory strategies, which just gives different techniques to help make the swallow more efficient or more safe. So they could hold their breath before swallowing, which closes off their 2 layers of airway protection. So the true vocal folds close and the false vocal folds can squeeze together to keep food or liquid from going into the airway. They could also put food on one side of the mouth. So if they have a weak tongue, we'll put it on the stronger side to help it chew up the food or push that food onto the chewing surface. Or we can have them turn their head to one side or the other. This is to help during the pharyngeal phase, to help the weak side of the pharynx squeeze together more efficiently and keep food from sticking in the throat.